Good morning, everyone. I'd like to talk about this ASL MR perfusion, which we could routinely use in all our MRI stroke protocol. This is a technique which helps us in understanding what area of penumbra exists in a patient who's having a stroke. So it is a very important component of decision making in revascularization. Let's discuss it with the case which we saw yesterday. This was a patient in whom he was a 62-year-old gentleman who came with inability to move his right upper limb and right lower limb with aphasia. So on diffusion weighted imaging, we are able to see an area of infarct which is seen in the right corona radiata, right capsular ganglionic region. On MR angio, what we are able to see is that there is a partial occlusion at the M1 M2 junction of the left middle cerebral artery, and there is an attenuated caliber of the distal M2 M3 M4 branches of the left middle cerebral artery. So this is a typical example of a small core, but there is a large area of tissue which is present. But the problem is this was the same appearance in diffusion weighted imaging in this patient, which was done at around 6 hours before. That is, even after 6 hours, when the diffusion weighted imaging was repeated, there was no progression of stroke. This is very important. Outside they had done an MRI in which we saw it was similar areas. There is similar area of M1 occlusion. There was similar area of infarct tissue. After 6 hours, when we are repeating it in our hospital, we are able to see the same thing. Now the question is whether to open it. As we saw, it is a case of partial occlusion. It is not completely, if it's completely occluded, we are going to definitely go in and open it up actually, because there's a large MCA territory, we're going to open it. Second thing is, will he progress or not? This is a very interesting and important question which is very difficult to answer. In our patient, we saw that there was a previous MRI which was available with the patient in whom the size of infarct was also same and the MR angiogram findings were also same, which was done 6 hours before, and he has not progressed. I'll tell about the clinical condition of this patient later actually. That helped us in one particular clue to whether to intervene or not. Now, if the patient has not progressed, the other question is, why has he not progressed? That could be because of the collaterals which came from the anterior cerebral artery and posterior cerebral artery, which we really do not know how long it is going to keep that area of the left MCA perfused. So what to do? That is where the ASL arterial spin labeling MR perfusion techniques comes into play. This is a very important technique because we use endogenous contrast. We don't administer contrast from outside. This is an endogenous contrast which is given to the patient, and we identify whether there is a penumbra tissue which is present in the patient. Here we are able to see that there is a large blackish area which is seen. So for the infarct which was here, the penumbra tissue is nearly the left MCA territory. And let me just play the actual video. This is the color images. Those of whom are very interested in color images, you can see there's a huge black area of reduced perfusion which is seen in the entire left MCA territory, which means this is a patient who's having a penumbra which is huge for a core which is very small, and there is partial occlusion, not complete occlusion. So this is a patient who merits revascularization, be it mechanical thrombectomy or aspiration or even IV thrombolysis. So moving on. So here we are able to see the angiogram images. Here we are seeing a small clot, a very tiny clot which is present in the M1 M2 junction of the left middle cerebral artery. This pre-procedure, it is also going into the superior divisional branch. Post procedure, we are able to see it is completely clean. There is no clot at all. There's one more thing I want you to see here. See, these areas of blackishness which we see is all the areas of perfusion which is occurring in these territories. And in the left MCA territory, this is the penumbra which is seen in the angiogram. See, the entire ACA and MCA, and even in the MCA, the inferior divisional branches are all showing good blush. But there is no blush in the area which will definitely get infarcted if this patient is allowed to be in the same position. So this is also an indirect evidence of and penumbra which is present in the patient. This is a clot which we retrieved. It's such a small clot. You can see it's hardly 2 mm, 3 mm. and this was a clot which was aspirated from the patient. This is a pre-procedure and post-procedure, only a subtle finding. There's a partial occlusion, the attenuated. Now you can see the distal collaterals are better. M2, M3 collaterals are better when compared to the previous image. And this is a MR perfusion technique, arterial spin labeling. What I showed earlier was a colorful technique. This is the source images. This is what we are more comfortable, where we can see how black it is and it has become totally white post perfusion. Diffusion weighted images, similar areas of perfusion, that is a good enough thing. And how do we assess the diffusion weighted images? It's using the ADC map. Before I show you the ADC map, I'll just show you this particular article. What this article states is, this is a very good article about ADC levels and its relation to diffusion weighted reversal in patients who have mechanical thrombectomy. It concludes that if the ADC is more than 0.5 or more than 520 in the power of 10 power minus 6. If it's 10 power minus 3, it is 0.5. They are salvageable by mechanical thrombectomy. It is a useful tool to predict viable tissues. Let me show in our patient. In our patient, the ADC value was 0.3. It was less than 0.5, but still, since this patient had a huge penumbra, we decided to still go ahead and open this particular blood vessel. And how was it post procedure? Similar areas. Can you see similar areas? The ADC reversal has occurred. It is not as black as it was earlier when the patient was occluded. Now if you see the ADC map, it is 0.6. So it has increased to more than 0.5. According to this article, if you had taken the interpretation, it means this area will not be salvageable. But this is one of those lucky patients who did extremely well, and even the core has got reversed. So to conclude, the take-home point is this. So use MR perfusion arterial spin labeling. It's a very important decision-making tool regarding whether to open it or not, especially in partial occlusion. In complete occlusion, usually ASL will be positive. There is no doubt regarding it. The second thing that we need to know is the ADC reversal. ADC reversal, if it occurs, so we already know that in whether there is an ADC reversal, it means the core infarct tissue has also been reperfused. The entire area of reason for doing mechanical thrombectomy is to prevent the penumbra from becoming into a infarct, which we have seen. But in ADC reversal, there's a next step which is happening. What is happening here is, even the tissue which is already dead, which we call it as core, even that has got reversed, which is what is called as ADC reversal, which is an important prognosticating factor in the overall prognosis, in the overall condition of the patient. And there is a core reversal which is occurring. Thank you.